Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of cervical lymphadenopathy for general pediatricians. Cervical lymphadenopathy is one of the most common reasons for outpatient pediatric visits, and the vast majority of cases are benign and self-limited. However, the pediatrician must be able to identify the red flags that point to serious underlying disease such as malignancy, tuberculosis, or Kawasaki disease. In this lecture, we will walk through 10 clinical cases covering clinical presentation, examination findings, differential diagnosis, investigations, treatment, special situations, and complications. By the end, you will have a clear, evidence-informed approach to evaluating any child with neck swelling. Let us begin. Question 1. A 4-year-old boy presents with a 2-day history of runny nose, cough, and bilateral neck swelling. He is afebrile and active. Examination reveals multiple 1 cm mobile, non-tender nodes in the anterior cervical chain bilaterally. What is the most likely diagnosis? Option A, viral upper respiratory infection. Option B, Group A streptococcal pharyngitis. Option C, acute bacterial lymphadenitis. Option D, cat scratch disease. The correct answer is option A, viral upper respiratory infection. Viral upper respiratory infections are by far the most common cause of acute bilateral cervical lymphadenopathy in children. The clinical clues here are classic: bilateral involvement, small node size of less than 2 cm, mobile and non-tender nodes, and an afebrile, well-appearing child with coryzal symptoms. Common viral causes include rhinovirus, adenovirus, influenza, parainfluenza, and respiratory syncytial virus. Bacterial lymphadenitis is almost always unilateral, with a single large tender node, fever, and overlying erythema. Management of viral reactive lymphadenopathy is purely supportive. Parents should be reassured that nodes may persist for several weeks even after the viral illness has resolved. Question 2. Physical examination. A 7-year-old girl presents with a 2.5 cm firm, fixed, non-tender node in the left supraclavicular fossa. She reports night sweats and a 2 kg weight loss over the past month. What is the most likely diagnosis? Option A, reactive lymphadenopathy. Option B, infectious mononucleosis. Option C, malignancy, for example, lymphoma. Option D, toxoplasmosis. The correct answer is option C, malignancy, most likely lymphoma. This case is a textbook collection of red flags. First, the location, a supraclavicular node, sometimes called Virchow's node on the left, is highly concerning for malignancy at any age and mandates urgent workup. Second, the consistency, firm and fixed, in contrast to the soft mobile feel of reactive nodes. Third, the size, greater than 2 cm. Fourth, the B symptoms, unexplained fever, drenching night sweats, and weight loss greater than 10% of body weight, which are classic for Hodgkin and non-Hodgkin lymphoma. Immediate workup includes a chest X-ray to look for mediastinal widening, complete blood count, lactate dehydrogenase, uric acid, and prompt referral for excisional biopsy. Fine needle aspiration is generally inadequate for diagnosing lymphoma because architectural detail is required. Question 3. Differential diagnosis. An 18-month-old male presents with a 3 cm warm, red, and very tender swelling on the right side of his neck that appeared 3 days ago. He has a fever of 39 degrees Celsius and no other symptoms. What is the most likely diagnosis? Option A, viral lymphadenitis. Option B, cat scratch disease. Option C, non-tuberculous mycobacteria. Option D, acute unilateral bacterial lymphadenitis. The correct answer is option D, acute unilateral bacterial lymphadenitis. The hallmarks here are rapid onset within days, unilateral involvement, a large tender node greater than 2 cm, overlying erythema and warmth, and systemic fever. The 2 organisms responsible for the great majority of cases are Staphylococcus aureus and Group A streptococcus. Empiric oral antibiotic therapy should cover both organisms. Cephalexin or amoxicillin clavulanate are appropriate first-line choices for 10 days. In communities with high methicillin-resistant Staphylococcus aureus rates, clindamycin should be considered. The child should be reassessed in 48 to 72 hours. If there is no improvement, if the node becomes fluctuant, or if systemic toxicity develops, further evaluation including imaging and possible drainage is required. Question 4. Investigations. A 5-year-old presents with a 4 cm tender neck mass. You suspect a developing abscess. Which imaging modality is the most appropriate initial step to differentiate between phlegmon and a drainable abscess? Option A, ultrasound of the neck. Option B, contrast-enhanced computed tomography scan. Option C, magnetic resonance imaging. Option D, plain X-ray of the neck. The correct answer is option A, ultrasound of the neck. Ultrasound is the preferred first-line imaging modality for pediatric superficial neck masses for several important reasons. It involves no ionizing radiation, requires no sedation, is widely available, and is highly accurate at distinguishing solid inflamed nodes, phlegmon, and fluid-filled abscesses. An abscess will appear as a hypoechoic or anechoic fluid collection with a rim of inflammation, and this finding directly guides the decision to perform needle aspiration or incision and drainage. Contrast-enhanced computed tomography is reserved for deep neck space infections such as retropharyngeal abscess when surgical planning requires detailed anatomy or when ultrasound is inconclusive. Magnetic resonance imaging is rarely needed acutely, and plain X-rays have almost no role here except in suspected retropharyngeal abscess. Question 5. Subacute or chronic case. A 10-year-old boy has a 3-week history of a large tender axillary and cervical node. His mother mentions they recently adopted a kitten. A small healing papule is noted on his forearm. What is the most likely diagnosis? Option A, sarcoidosis. Option B, cat scratch disease. Option C, tularemia. Option D, tuberculosis. The correct answer is option B, cat scratch disease. Cat scratch disease is caused by Bartonella henselae, a gram-negative bacillus transmitted through the scratch or bite of an infected kitten, most often a young cat under 1 year old. The classic triad is a history of cat exposure, a small healing inoculation papule at the scratch site, and regional subacute lymphadenopathy developing 1 to 3 weeks later. The most commonly involved nodes are axillary, cervical, and epitrochlear, depending on where the scratch occurred. Diagnosis is primarily clinical, supported by Bartonella henselae serology. The disease is self-limited in most immunocompetent children, resolving over 2 to 4 months. Azithromycin for 5 days may shorten the course in patients with significant lymphadenopathy. Rare complications include paranode oculoglandular syndrome, hepatosplenic disease, and encephalopathy. Question 6. Treatment selection. A 3-year-old presents with a painless 4 cm submandibular node that has been present for 6 weeks. The skin over the node has a characteristic violaceous or purplish hue. He is otherwise well. What is the most appropriate treatment? Option A, 10 days of amoxicillin clavulanate. Option B, 6 months of anti-tuberculosis therapy. Option C, surgical excision of the node. Option D, incision and drainage. The correct answer is option C, surgical excision of the node. This is the classic presentation of non-tuberculous mycobacterial lymphadenitis, most often caused by Mycobacterium avium complex. 3 features should make you think of this diagnosis: a young child between 1 and 5 years old, a chronic painless unilateral submandibular or upper cervical node, and the pathognomonic violaceous, thin, parchment-like skin overlying the node. The child is systemically well in contrast to tuberculosis. Treatment of choice is complete surgical excision, which is both diagnostic and curative, with cure rates above 90%. Incision and drainage is contraindicated because it almost always leads to chronic draining sinus tracts and prolonged scarring. Standard antibiotics are ineffective, and anti-tuberculosis therapy is reserved for true tuberculosis, which would typically show a positive tuberculin skin test or interferon gamma release assay. Question 7. Special situations. A 2-year-old boy has a 6-day history of high fever up to 40 degrees Celsius. Examination reveals bilateral conjunctival injection, cracked lips, a strawberry tongue, and a single 2 cm tender right cervical node. What is the most likely diagnosis? Option A, scarlet fever. Option B, Epstein-Barr virus. Option C, measles. Option D, Kawasaki disease. The correct answer